The early studies had demonstrated that there was a sort of threshold around a CD4 count of 200. If you started treatment when the CD4 count was below 200, the response was absolutely less good in every study than people who started at a CD4 count above 200. So we knew that if you started too late, it was not a good thing. But it left completely open when was early enough, when was too early, and that balance, to be honest, has taken 15 years to start to address in terms of formal clinical trials. I think had the toxicity of the drugs not been so overt, not in these extraordinary lipid changes, I think that people would have felt the drugs were more safe. So toxicity, high pill burden, the increasing evidence of need for adherence, everything pointed to starting when people were starting to get sick, but before they were too sick, when they would be most adherent to therapy and where the risk-benefit was very clear. What's changed is that the drugs have got easier, one pill once a day, can't get easier than that, and the toxicities have got less and are more manageable and more anticipated, so you can warn patients about them. So the starting point has crept up. Without new evidence, it's just all over the world. The starting point has crept up, and now we're at that point in history where we can say hit early, hit hard. Perhaps we need to revisit it.
For such a strategy to work, we've got to show that the individual who's going to take the treatment is going to be of benefit to them as well. I don't think that one can implement such a strategy by saying, we don't know whether starting to take treatment very early is going to be of benefit to you, given the toxicity of the drug, given that you have taken for life. But I think it's a good idea for you to take them so that, will help public health instead of not transmitting. I think if you give an intervention for somebody, I think your primary concern will be is benefiting that individual who is taking the treatment. And if they know that, and then if as a consequence of that, they're going to benefit other people, then it's all. So from a public health point of view, there's a good rationale for test and treat. It is just not practical to implement it unless we show that early treatment is also of benefit to the individual. And that is what the question start is addressing.
The trouble is, it does emphasise that I am a sick person if I'm starting on treatment. And I think that is one of the biggest fundamental questions about whether somebody should start treatment early or not. For me, it wasn't an issue, but I could see how it could be an issue. I think if there's very clear clinical evidence that the outcomes are improved by starting treatment, then I think we should be working to help people with that psychological barrier. But I think while the outcomes are still questionable, I think that's a difficult one.
My perspective is entirely different because I wanted to do it, but I could see how someone could be frightened after being told that, well, you're infected and now you've got to go on medicine. Psychologically, I don't know what effect that has, but it certainly is scary.
Well, I think you have to go back to things like smallpox. I mean, at some point you have to say, this is for the good of the world, and if it's not harming the individual, then I think, there's every reason to go for it. How on earth you get people to do blood tests, that's a political, logistical problem. But I just don't think you can take that chance. If it's proven that infection rates are lowered by people being on antiretrovirals from diagnosis, then surely that is one way of controlling the epidemic until such time as some kind of cure is found. I think it's logical.
I think when you took treatment, you will become healthy. You won't get sick. Yeah.
The best course, from my experience, is that if someone is told what the facts are, what the prognosis is, all the different variety of drugs and combinations, the facts about expected life expectancy with the virus, that there's enough time to prepare that person so that they're knowledgeable enough that when that option is made to them, should they start, it's something they're going to have to get used to anyway. So, I mean, I'm the type of person that when it's clear what the ultimate outcome is, I just soon bite the bullet and get on with it. And I think a lot of people would feel the same way.
We are talking about this in my sitting room in England, in sunny, wealthy southern England. You know, these medications are not cheap, and it's who is going to pay for them if we start these people on early, if there's no real clinical evidence they're going to be effective. Third world countries are struggling, even first world countries like America, where there's not free healthcare for all. Some people struggle to pay for their medication.
Currently, we don't have all the people that need treatment getting treatment. So I believe that the test and treat concept may be feasible in some countries, but not in a very generalized epidemic as South Africa, because the people who need treatment currently are not getting treatment.
It would mean a lot more resources now to save resources for the future. But otherwise, antiretrovirals represent a sort of debt burden which can only increase, because without halting transmission, the prevalence of HIV infection can only rise.